Hello, I'm Michael Pierce, and this is The Human Condition. Today we're talking about tips and tricks for mild traumatic brain injury, mild and moderate traumatic brain injury, and post-concussion syndrome. So mild traumatic brain injury is usually an injury that affects about 4 or 5 different systems and criteria in the brain after some kind of impact. Now that impact is the brain moving inside the head, so it does not require your head to hit something. A mild traumatic brain injury is usually related to where your head is whipped, like in whiplash, where your neck is whipped, and that happens in car accidents. It happens in sports all the time. It happens in falls on the ice and slips and falls. It happens in many, many human endeavors. It can be very, very, very small and mild, and it can be very, very large. Now, typically, traumatic brain injury, or a TBI without the M in front of it, is a little more serious. We tend to talk about the severe TBIs as the ones that have the skull is not intact, it's broken, and something either comes out of the head or goes into the head, a penetrating wound. Mild traumatic brain injury to moderate traumatic brain injury is usually a closed head wound and not an open head wound. And usually what happens is for 30 minutes or less, there is some kind of symptom that has to do with cognitive processing or emotional sensation or neurological, sensory or motor balance processing and loss of memory. So those 4 categories are the ones that happen on the field when a person gets like a sports concussion, and we call these concussions colloquially. But the idea is that you will have some or other of these symptoms for less than 30 minutes and they recover. Now, most of the time we're not talking about a loss of memory or a loss of consciousness, although it's possible for a person to have that. We're not looking at, coma scales right now. Coma scales are involved in the moderate and severe. But for the mild, we're not talking about the Glasgow Coma Scale. We're not talking about someone who can't talk after an injury. We're not talking about someone who can't walk. Those are much more serious. We're talking about someone who gets hit maybe with a soccer ball or tackled in football in high school, and they have maybe numb and tingly hands, and they can't quite remember what day it is today for less than 30 minutes, or they feel really moody and they feel really combative, or they get really, really kind of weepy, or their emotional state changes. Later on, they'll have sleep changes, but you can't assess sleep changes on the field or in the actual arena when something happens in a sports injury or in a war injury, because we're not sleeping. So you don't have a sleep effect until you go to bed that next night. And sometimes it takes weeks for the brain to register this and give a sleep pattern change. So a person may have, whiplash neck pain or sleep pain 2 weeks or later after the impact that happens to them. So you can't rely on the first 2 weeks necessarily as accurate information. You have to track them over a longer period of time. Headache is a big factor in this. And in fact, in my opinion, as a chiropractic neurologist, it's very hard to have a mild traumatic brain injury that doesn't involve a neck whiplash, or a neck whiplash that doesn't involve a mild traumatic brain injury. So when you've got one, you have to investigate for the other. These are comorbidities. They occur together, and they're extremely important. One of the things that I like to do is actually x-ray the neck in a Davis series, which includes bending forward and bending back x-rays from the side to show if there are damage to the ligaments. Sometimes a person can have some really bad head and eye symptoms that they think are related to the brain, but they're actually related to the neck. So you need to differentially diagnose neck versus brain injury. The neurological examination is probably the most important part of assessing a mild traumatic brain injury, and that includes a complete neurologic exam or a focused neurologic exam that looks at cranial nerves or the motor and sensory system, reflexes. It looks at balance and speed and timing, alternating movements like this. It looks at eye movements of several types, and it looks at vestibular things like the inner ears and how they operate and how they work. A very skilled history-taking doctor can do a history and an exam and localize where the brain seems to be okay and where the brain seems to be not okay and where it needs attention. And they can prescribe exercises and diagnose where the lesion is. And then they follow that up with things like a QEEG or an ERP test that measures brain waves. And sometimes those correlate very nicely, and sometimes they don't correlate because they measure different things. So it's useful to have both, because it's like the difference between an X-ray and an MRI. They measure different things, and they're good at certain things and bad at other things. I think it's very important to make sure that a person with MTBI gets regular neuro rehab after they get a neuro exam. That means they've got to get chiropractic adjustments. They've got to have eye exercises, balance exercises, sensory stimulation. We call this sensory integration therapy or hemispheric integration therapy that's used. It's a neurological therapy that's designed to stimulate people just enough to heal their brain, but not so much that it overwhelms them. Because you'll find that people that have a mild traumatic brain injury, certain parts of their brain are very fragile and they don't respond well to overstimulation. So you can't use heavy-handed rehab. And this is something that we have to be very careful in chiropractic and physical therapy to not overdo the rehab in either intensity, duration, or excursion, how far we move the person. We have to minimize everything and make it a lot smaller than the standard testing because the person's tolerances are much lower and their neural fatigue is very high. One of the hallmarks of this is that when you do a test that seems trivial, like for example pursuits, when they follow a moving target, they might fail to follow that moving target and they might have skips in their eye movements. That would be a breakdown or an error in pursuit smooth movements or smooth pursuit movements. When that happens, we can localize that to different brain areas when we combine it with other findings, and that way we can start to fix somebody. But the rehab would have to be very, very slow, much slower than a typical test. If a person's typically tested for a pursuit and the pursuit looks like this and they're fine, that's not going to be the rehab for a person who is impaired with pursuits. They might have to do very small pursuits that are very slow, and they may not be able to do more than a few reps of them before they fatigue. And most importantly, they may or may not be able to perform the task, but they might start to sweat and have autonomic breakthrough symptoms where they sweat, they have a rapid heartbeat, their blood oxygen level on their finger goes down, their perfusion goes down, they might have a sense of anxiety, they might have shortness of breath or rapid breathing, their respiration goes up. These are all symptoms of a person who is fatiguing and is being overdriven during rehab for an MTBI. Perhaps my favorite natural anti-inflammatory for the brain during this process is turmeric. Turmeric can be given as a dry herb, often mixed with black pepper to help its absorption because it's hard to absorb, or given in a liquid or oil form. Turmeric is much more easily absorbed when mixed with oils, so you'll find that liquid turmeric that's mixed in oils is often given. Turmeric or curcumin, which is one of the active ingredients in turmeric, is very useful for helping people get better. I like Boswellia serrata as well. And there's also a controversial approach for this which says that, plant medicines may not always be the best, and sometimes just going carnivore is a great idea. I am a big fan of ketogenic diets and carnivore diets for brain injuries because the literature shows that brains of all types do very, very well when they're injured when they are starved of carbohydrates and fed fats. So when you reduce carbohydrate and feed fat, you get a much more stable chemistry with a lot less oxidative damage and oxidative stress and a lot less oxidated cholesterol. The approach of switching a person over to a very low-carb diet or a carnivore diet, if they have a brain injury, is a very sound approach, but it requires proper medical management, someone that knows how to do blood tests and lab tests and look at ketones if they're doing a ketogenic diet, and make sure the patient is properly taken care of so they don't have any side effects, because a person that has a head injury is not very well able to manage themselves. So I think that a person with a mild traumatic brain injury should have a buddy. They should have somebody with them who is an advocate, a patient advocate, a family member, a friend, someone who comes to the doctor with them and helps them do their exercises and helps them keep track of all their stuff. Because when they go to the doctor and the doctor tells them their plan of treatment of what to do, they've got a brain injury. How are they going to remember that? How are they going to keep it straight? How are they going to track it? Are they going to go home and make a spreadsheet and track their supplements and their brain exercises and their diet and their symptoms and their sleep? No way. They're not going to do that. So they need a friend that can help them do that. And I think it's really important to consider elimination diets like that. QEEG guided neurofeedback. Infraslow fluctuation is a very, very good form of neurofeedback that I use for this. S. Loretta deep brain neurofeedback to the limbic system is very useful for this, especially if there's a big emotional component to MTBI. It's very, very useful. And don't forget, you've got to get omega-3s. The EPA and DHA fats, eicosapentaenoic acid and docosahexaenoic acid, which are the EPA and DHA. These are the omega-3 fats you need to form good signaling and good structure in your brain after an injury or after any kind of trauma to rebuild fatty-based membranes, because all of the membranes in our cells and tissues are made of fats. The phospholipid bilayer is made of lipid, which is fat, and so is the cholesterol fatty myelin that surrounds all of our nerve cells and insulates them. That's the fat that's attacked during MS, for example. If you have multiple sclerosis, that myelin is attacked by the immune system. So you've got to have and regrow this healthy myelin when you have a brain injury, because sometimes you can get axonal shearing, which is where all these fibers that are like strands of spaghetti that go through your brain, these highways, they can get sheared off, and they can heal and recover, but they require lots of protein and lots of minerals and lots of fat in order to regrow and reattach and heal, because these axons can shear. These fibers can shear off at the phase where they change from being a white matter highway and they enter gray matter, and they interact with other cells. That particular boundary or domain can shift and shear mechanically because it's different. One is softer than the other, and so they actually mechanically respond differently to inertia forces when the brain is whipped inside the head. So I hope this has been useful for you. I think it's very useful to check all this stuff and be aware that there's a lot you can do for the brain besides bed rest and counseling, and there's a few drugs that are given for MTBI, but I really think that there's a lot more that can be done for MTBI.